Hello, everybody. My name is Carlo Di Lorenzo, and I'm a pediatric gastroenterologist from a nationwide children's hospital in Columbus, Ohio. And we are here at the GI ReConnect. I think it's the 5th conference in beautiful Denver, Colorado. And I'm happy to have two illustrious pediatric gastroenterologists here in this podcast. We'll be discussing congenital or genetic sucrase-isomaltase deficiency. To my right is Dr. Ankur Chugh from Children's Wisconsin. To my left, we have Dr. Khalil El-Chammas from Cincinnati Children's. Welcome. Why don't you start by telling me, how did you develop an interest in this somewhat rare and esoteric condition, CSID? Do you want to start, Ankur?
Sure, I'd be happy to. I think like many of us, our trainings during fellowship was variable, and depending who you had on service that week as an attending might depend on what you learned about or what they were passionate about. And in my training, there was only one attending that sent Diasacs. I never understood why he would send those Diasacs, but he would. And then I was never really involved in the interpretation of them. So you could say that I didn't know much about Diasacs during my fellowship outside of the traditional congenital CSID, that rare, kid at birth with a profuse diarrhea, which I never saw, right, given how rare it is. Then I get to my attending job at Children's Wisconsin, and here we have a Diasacs lab. Steve Werlin is there. He's published, 50 papers plus, and many of them on Diasacs, and so I've got an expert there. I hear about Adrian Miranda, who's also a local expert in Diasacs. Now I've got two people around me who are well thought leaders in this topic, and then a year into my being an attending, Steve Werlin retires, and they say, do you want to be the clinical consultant for the Diasacs lab? And as somebody who is not very good at saying no, I said yes. So then I would start to receive the calls from outside physicians saying, hey, help me interpret these Diasacs. So I think from there, I studied, I read all the papers. I would talk to Dr. Werlin, Dr. Miranda, and then through many years of research and interpreting and experience, learned about Diasacs in terms of how to interpret and how to order them from my standpoint.
Okay. That's great. That makes you a true expert. What about your Khalil? It feels like there is a little bit of an overlap.
There is.
This story. Can you tell us why you developed this interest?
Yeah. Similar to Ankur's experience, my interest and awareness was nurtured by an attending, or two attendings actually. And interestingly, I did my fellowship at Children's Wisconsin, mentored by Dr. Werlin and Dr. Miranda. And I was doing a continuity care clinic with Dr. Miranda. And of course, he sees a lot of patients with chronic abdominal pain. And we were brainstorming one day, and we decided to reevaluate the frequencies of Diasac deficiencies in this patient population. And so we had a prospective study come out of this. And I learned that the ratios or the percentages of the kids with chronic abdominal pain and Diasac deficiencies were more commonly than previously reported. But we also found out that the ratio, the sucrase to lactase ratio, didn't really have an effect when you look at age and other symptoms, symptom severity and symptom reporting by those patients. So it was an eye-opener. And also then we realized there's more to learn about Diasac deficiencies, diagnostics, teaching, and we joined forces with Ankur and other specialists who deal with this, and we have just a lot of brainstorming and thinking to do.
All right. So you guys have a legitimacy. I think we have two true experts here. Let's pick some controversial topic, right? So we're not going to be able to discuss everything about CSID, but let's start with a fairly basic one. In whom should we test for disaccharидase deficiency, specifically for CSID? We do a lot of endoscopy. Should we take biopsy in everybody in whom we do an endoscopy to check for this? I don't know. Ankur, you want to take it this?
Yeah. So again, like you said, Carlo, this is a controversial topic. And I think our group that's been looking at this is trying to make some headway and make it a little bit less controversial, because the practice variability on this topic is across the map. Stan Cohen's group did a nice study on this out of their group in Atlanta that looked at the 13, I think, folks there and looked at who ordered Diasacs and when. And then you had some folks ordering it for every patient with a scope and others ordering it almost never. And so it tells you that there is this range of practice styles. And then you have to kind of go to the literature and try to figure out what do you think you should do based on this. And so I think the symptoms of a deficiency that seem, logically and intuitively more predictive of this kind of disorder would be things like bloating, or gas or diarrhea. And I think some of us feel, comfortable getting it in that case. Going through the effort of sedating a kid, putting them under, looking for a cause, that adds just a few extra biopsies, not much extra time, not a lot of costs in the grand scheme of things. And so I think if you can find a potential cause of their problems that's treatable in a very different way than, say, a DGBI, with a dietary change or an enzyme, that's important to get. The controversial piece, I think, is the abdominal pain, and do you order it in a kid with belly pain? I personally do, because I think, again, I'm looking for an answer to their problem, and I think abdominal pain alone is maybe not as common, and there's always, at least in kids who are younger, it's hard for them to describe their symptoms. So for me, if I'm choosing to get a scope, and there's any of those symptoms, abdominal pain, gas, bloating, diarrhea, I will get a DISAC assay with it.
Yeah, pretty much your practice is very similar. From what I'm hearing, is that if you scope for EOE or for constipation, predominant IBS, or to follow up on H. pylori, don't do it. But almost everybody else, should we do it? Or what's your take on this?
I agree with Ankur. Also, based on back to my study, which is one of several studies that have shown a good proportion of patients with chronic abdominal pain having DISAC deficiencies. So I don't want to ignore that high percentage or group. And so when it comes to abdominal pain that's chronic, I don't think it's a bad idea. Like you said, you're in the scope.
Yeah.
There's some additional cost, but in the grand scheme of things, it may be helpful to diagnose something if the biopsies do come back normal. But then again, if it's a scope being performed for dysphagia or something else, then I may not really think of DISACs as a diagnostic modality at that point in time.
That makes sense. All right, let's say that you got your biopsies, you send it to the lab, you wait your 5-7 days, you get the results, and it comes back, everything is decreased. You have what people have called a pan-disaccharidase deficiency. What are you going to do about that now? You're going to do another test? You're going to treat? You're going to redo the scope? What is the next step in your practice? This is not that unusual. It happens. So,
correct.
What would be your take?
Yeah. First, I'd say, oh boy, what do we do with this? Then I would look at the biopsies and the histology and see, was there any abnormality in the cells that may explain this? Or was it, but then think of a sampling error. Was it a disease where it can be patchy and you just got a bad part or a bad biopsy site? But then again, going back to the patient, the symptoms, and the fact that you did test for it, you don't want to ignore it, in my opinion. And then you talk to the family and the patient and see if treatment is an option. Can we think of treatment to see if this will get better, if this is a true pan-disaccharidase deficiency or not? Because you want the symptoms to get better at the end of the day, assuming everything else came back normal.
All right, so maybe for you do a time-limited interventions and see what happens, the symptoms, and you go from there.
Yeah.
I think, I just to echo Khalil, kind of what you were referring to, I think it's the reason I don't get the DISACs in some of the patients like with EOE or with celiac or Crohn's, because, in EOE, it should be non-contributory to their symptoms, presumably. In celiac and Crohn's, you have other causes, of their enteropathy. And so I'm trying not to deal with more information that sometimes is hard for a family to kind of handle, because sometimes they see an abnormal result and they want to answer. If you tell them it's just a false sampling, nobody's satisfied with that, right? They're like, I paid for this test, I went through the trouble. So nobody likes that answer. And I think we don't want to brush it off. I think sequentially, you can start with, lactose, reductions or therapies, because that's more common, than a sucrase deficiency overall in that regard. And I think another thing, like you said, is to just take the sample weight, because there are issues where if you don't get enough biopsies or the samples are too small, you will get a falsely positive sample with a pan-DISAC deficiency too. So some of the labs will report their values of the weight of the sample, which we do for that reason.
So actually, can you elaborate a little bit more on this? The director of a lab, what message can you give to people who collect the biopsy? So I heard some people taking just one biopsy, some people take 2 or 3. Is there any value in taking even more? And from where? What is the most common downfalls of sending the sample to the lab?
Yeah. And so clinical consultant to the lab, just to be clear on the title. But no, I think a couple of things are important. I think, for me personally, I used to take 2 biopsies, which is what I was recommended. And then this is before I was director of the lab, and I would get more of these pan deficiencies. And I said, what is going on? And then I would, scope sometimes with a senior colleague, and then he would get 2 and his would be fine. But then I looked at his biopsies and they were like twice the size of mine. And I don't know why the same forceps could generate, right? But it makes sense, different force. And then I went to learn about the way the test was done, and they actually take the samples, they homogenize them. So the sample weight and size does matter. And so for somebody who biopsies for whatever reason are smaller like mine, I actually do need 3, sometimes even 4, in order to get that sample. And that actually reduced my false positives in a really nice way. I'll actually have my tech tell me, how do those pieces look? Are they good samples or not? And then if it's a new tech, I'll actually turn my head around and look at the samples to see. And that actually has helped quite a bit, in addition to making sure they get on ice and on dry ice fast to get to to prevent degradation.
That's very helpful, practical information. Okay, so now you got the right patients, you got the right biopsy, you got results coming back. Now you have a patient that has a low sucrase-isomaltase. What are we going to tell the family? Do we have a treatment for you? What is the treatment? Are we going to use enzymes? We're going to use a dietary exclusion diet? What will be your first intervention in a case in which you feel pretty strongly the patient has a sucrase-isomaltase deficiency?
Yeah, great point and question. I think a discussion with the family on the options we have available for the child is really important. They both have pros and cons. And we are not sure at this point in time if we should do both at the same time and then taper off, or try one and then add on therapy afterwards if we don't see an improvement in symptoms. I think just talking to the family about each one as an option and coming to a shared decision making. Do we want to try both routes at the same time first? Is it doable? Is it cost an issue? What to expect? And then how to, do follow up and go from there. That would be my first attack, really.
So you will start full course first, get some good results, and then eventually try to maybe wean for one of the interventions. Is that a similar approach that you would take as well, Ankur?
Yeah. No, I think that shared decision making is important, and it's also important to figure out if the enzymes are covered by insurance overall. In terms of the prescription. There are generics that are out there, but again, those haven't been studied, so we don't know if they work as well. But that can be another option for a family. I always remind a family that this isn't dangerous in the sense that there's not being damage that's being caused there, but certainly the symptoms are impactful. And so having them do that trial for a couple of weeks of diet or enzymes gives us a sense of if they respond. And we were talking about this yesterday about, what do we do after that first trial? I think if there's no response, then I think we just put this to the side and say, this isn't related to your symptoms, because the symptoms can be multifactorial. And then if they get a great response, we'd maybe continue it and maybe try to wean in 6 months like we do for other things. And then the middle category of if they partially responded is, I think, the one that we were debating. Do we then try to eliminate starch on top of that, recognizing that some people need that as well? I don't know if, Khalil, you go that far or not, but we worry about these elimination diets in children, and how many things do you take out, but we're balancing that with trying to improve their symptoms. So
yeah.
How quickly do you expect an improvement? Is that something that it will take weeks, or the child feels better like 2 or 3 days after starting treatment? I don't know. What's your experience?
Hard to really give a timeline, but I would say at least a week or 2.
Okay.
Just with other experience from other trials of other medicines and dietary interventions. Yeah. What do you think?
I think so too. I think there's sometimes people takes a while to get in the swing of taking a medicine regularly. I forgot to take it this day. Or, I took it once, only twice. I think you've developed some, probably, you've probably gotten used to certain things in terms of the way your body feels, and to kind of unlearn those pain signals or discomfort signals and actually feel that takes more than, I think, a day or 2 in my experience too. But within 2 weeks, I think we do see that response, a week to 2 weeks.
Mm-hmm. All right. And where do you see the field going now? I mean, we heard, this was a condition that people did not even have on their radar screen in, 5-10 years ago. Now we're beginning to hear a little bit more as a mimicker of IBS, or something to consider in patients that have specific phenotype. What is the next step to understand a little bit more, to get more clarity on CSID? I don't know. Why don't you take this, Khalil?
We've been in discussion for a few months now, but we both, a lot of us realize there's a lot of variability and the diagnostic technique of when to screen and how to take biopsies and et cetera, and how to interpret results. I think we need to come together and just come up with some unified approach to this. And then once we do, have a teaching model for fellows and for junior faculty, just so that patients, wherever they go, they might have the same diagnostic application if this is being considered as a potential diagnosis.
Yeah, I think the other thing that we need to work on is really trying to figure out who responds to the diet and what does that longitudinal follow-up look like. And so most of the studies, are looking at the percentage of deficiencies across different types of populations, but there are very few studies that look at patients over, say, 3 months, 6 months. We had the initial study that led to the drug getting approved back in, I think, 2012. That was still small numbers of patients, but since then, we haven't had like a registry or folks saying, I'm going to look at this out for 2 years and see of the people that I diagnosed with this and I treated, how many responded in 2 weeks, how many stayed on it, and how many kept on it for a year, 2 years, how many modified their diet, how many took the enzyme, once a day, twice a day. We don't have any of that data. I think for us to figure this out, we need to get that data and then ultimately try to figure out the predictor rates of, knowing ahead of time, like these are the phenotypes of the patients or the features of the DISAC assay that are going to predict who's going to respond.
Any other word of wisdom? Any other last message you want to send to pediatric and adult gastroenterologists that are sometimes dealing with this condition?
We have a lot of work to do. We should work together to get the most out of this.
Yeah, and I would say have an open mind. I think this has been such not a polarizing issue in some ways, or people have very kind of fixed mindsets on it, given sort of what we learned, 20 years ago with the congenital version. Just know that it's evolving, and have an open mind, because if you do make this diagnosis, which seems to be around 8% is what most of the studies are saying right now, right? It can be a very different course for a family than not having this diagnosis.
And I think we need to also thank GI Health Foundation, because I understand they are in the middle of coming up with a slide set that people may be able to use in giving presentation about this condition. I think there is a primer document that hope to be published in the next few months, so that support has been invaluable to try to increase knowledge about this condition. All right, with this, I want to thank Dr. El-Chammas and Dr. Chugh for their expert opinion on this condition, and I say bye to everybody who listened. Thank you.